So I'd like to thank the Sport Association for asking me to speak. I'd like to thank Drew for basically covering my talk already, so thank you.
I only had one slide, 2 slides.
So to start with the problem with steroids, I guess, if we consider the problem with ITP first, and there is quite diverse origins to it. I'm not going to go through that in detail, but that perhaps answers the question of, well, why steroids at all? Because actually steroids have quite a diffuse effect on the immune system. They have generalized anti-inflammatory effects, and so they're effective, and so they do remain our first-line treatment. And so for now, we are stuck with steroids. But of course, they do have side effects, and perhaps the most common side effects that patients experience are these. So bloating, weight gain, anxiety, depression, fatigue. And I don't know if that resonates. This was a large survey of patients and clinicians asking important questions about, well, what is your symptom burden? And I think it's interesting that actually some of those symptoms map quite well into the total symptom burden of patients with ITP. In other words, I suspect steroids are one significant contributor to some of the overall troubles that patients have. So in that graphic, essentially the ones highlighted there are those that are most common and bothersome. So fatigue, anxiety, depression, again, are right up there. And on the left, we're asking the question, patients are asked the question, well, which treatment do you like the least, or which are you least satisfied with? And again, of the medical therapies, corticosteroids take it. Patients really don't like them. And this is another patient survey, and essentially says the same thing. Which is the medical treatment that has the highest symptom burden? And again, corticosteroids take the crown. And to add insult to injury, medics don't really appreciate this or underestimate the burden of steroids when it comes to patients. And we worry about different things as well. So rather than focusing on some of those symptoms that trouble people, we worry about other things that steroids do. And it's a long list, unfortunately. So if you take steroids for long enough, you can develop diabetes, high blood pressure, cardiovascular problems, bone thinning, and hypoadrenalism. So essentially the body makes its own natural steroids. And so if you take steroid for long enough, then the adrenal gland can get sleepy and not produce natural steroid. And the problem with that is that you can, as you taper and stop the steroid, then you can be less able to make a natural response to infections if they come along. So that's secondary hypoadrenalism. And this slide essentially makes the point that the higher your total cumulative dose of steroid, the more likely you are to hit some of these problems. This is data from asthma patients on long-term steroids. And essentially it says all the morbidities, the problems you get with steroids are more likely the higher the cumulative dose is of steroid. And that essentially works across the piece for all these problems that I mentioned. So coming back to what patients say again, the question is, how do we use steroids in clinical practice? And we use a lot of steroids, turns out. And so it's the most common treatment first line that we use, but actually also in second line and so on. Again, we're doing the same thing. We're using steroids because they're quick and they help rescue low platelet counts. And that's pretty consistent across the world. So if you look at surveys from France or Germany, same sort of story. So we use similar doses. Drew mentioned 1 milligram per kilogram per day. Again, that's French data saying a similar starting dose is used. And then a German study, I think this one's interesting because some patients are on steroids for really quite a long time. Drew mentioned trying to taper your steroids off within 6 to 8 weeks. There's about a third of patients receiving steroids first line who are on it for over a year. It's a long time. And then again, second line steroids, third line steroids, a significant portion of patients on them for over a year. And this is American data. This is claims databases. So this is very large numbers of patients. It's probably correct. And again, steroids were the most frequently used drug And again, the most commonly used drug, both first, second, third, it's consistent about 90 odd percent using steroids with each relapse should it occur. So what can we do to minimize the burden of steroids? Well, ideally not use them, but we're, as I said, currently needing to use steroids, but use the minimum effective dose and duration of steroids. And then if patients are needing them at relapse, ask the question, well, was it effective the first time? Or is the individual steroid responsive? If they are steroid responsive, well, maybe you don't need such a high dose the second time round. And then philosophically, think of steroids as a rescue rather than the line of treatment. That's a personal opinion, but if it's used second line, if somebody's relapsed once, they'll probably relapse again and again. So you need to find an alternative steroid-sparing treatment so that you can get individuals off a drug with relatively poor tolerance. And then it comes to trying to manage side effects if it is necessary to be on steroids. And this is individually risk assessed, so not everybody needs everything, otherwise you end up on a lot of tablets. But there are some individuals who have low platelets, therefore bleeding risk. Steroid can be a gastric irritant. So some patients may benefit from an antacid tablet. Treatment for bone thinning may be helpful, particularly in older individuals. Assessing and informing patients around the potential for adrenal insufficiency, which I mentioned, can be helpful. And then there may be some who are at high risk of infection, for example, those on longer-term steroids who might benefit from specific antibiotics. That little red box has wandered up. So this is just a reflection on, I mentioned, cumulative dose of steroids, and this just looks at 3 different steroid regimens. Prednisolone and dexamethasone are 2 steroids that are commonly used. Dexamethasone has some advantages because it's short pulses, so it's 4 days of dexamethasone, sometimes repeated 2 or 3 times. So that's nice because you're not taking steroids all the time. Or prednisolone that may be given for at 1 milligram per kilogram for 3 weeks and then gradually tapered. And those are perhaps the most common regimens. One of the problems with the short pulses is if you actually add up the total amount of steroid, then actually the cumulative dose is relatively high. If you convert it, the dex, to the prednisolone dose, then actually you're still taking quite a lot of steroid. So, and again, this is a personal opinion, the middle one, if you can see, is a lower cumulative dose. And the idea there is you take just 4 days at 1 milligram per kilogram and then taper. So that regimen gets you off steroids in about 8 weeks. But the cumulative dose is less. So that would be my preferred steroid regimen. And as Drew alluded to, then there are a number of guidelines that are thinking about this a little bit more and encouraging clinicians to shorten their dose of steroid, put a ceiling on the number of doses. So with dexamethasone, don't go beyond 3 pulses of dexamethasone, don't go above 80 milligrams of prednisolone. And there are places to turn if you're sort of trying to think through what or which patients might benefit from bone thinning prevention treatments. And NICE, the National Institute of Clinical Excellence, has given some guidance to clinicians about monitoring when individuals are on steroids. So steroids are used for lots of medical conditions. There's a lot of people on steroids out there. And so this is general advice, not specific to ITP. So again, there's a number of places that you can turn to sort of have a pathway and a systematic way of trying to minimize steroid side effects. So as clinicians, we're not great at this. We're patchy at best, and this is an audit that we carried out through the ITP forum, the clinicians group, simply asking the questions, well, are you handing out the steroid card as per the NICE guidance, and are you informing patients of this potential for an underactive adrenal gland? Do you assess adrenal function as you stop the steroid? And these were the results. Not brilliant, so only a third handed out a steroid card, 1 in 10 talked to patients about an underactive adrenal gland, and none routinely looked at normal adrenal function. So we've got a way to go. We're re-auditing this at the moment. So, okay, thank you very much.
Okay, any questions for Quentin? Adrian.
Thanks, Quentin. That's a really nice review of the use and problems of steroids. I mean, as an association, we've always been pushing the fact that patients should be taking ownership of their own treatment. I know patients are often reluctant to do that when they're sitting in front of someone looking distinguished like Drew or David or yourself. Is there something we as an association ought to be trying to push with our patients to encourage them to say to their clinicians, what protocol you are offering me as I follow this? What should I be doing? What's the minimum that I should insist on? Do you think there's something, well, I mean, you've been through some of things. Is there something just defined that we ought to be pushing, saying these are the minimum number of questions you ought to ask your clinician?
Yeah. And so I guess that takes us to the shared decision-making document that was done with the Support Association and is online. And it's really just about talking to the clinician and working together with a problem like that. And I think that document's really good. It gives a bit of information. It sort of provides a framework. So, you know, if you download that, you've got little prompts, right? Okay, what are you going to talk to your doctor about at your next appointment? And then you can just bring that in, because you can sort of, you know, if you rush through it can be difficult. And just sort of ask, right, how long is the steroid going to be for? You know, what are the monitoring process? I think if you ask those questions, it helps trigger in your clinician, oh, okay, so what should I be thinking about? What is this duration? And that's a nice way to sort of have that relationship, rather than sort of, right, why aren't you doing this? And, you know, so I think it's just building that relationship.
Okay, Quentin, one here.
Hi. When I was diagnosed with ITP back in 2000, I was put on 60 milligrams of prednisone a day for 6 months, and my platelets never went up higher than, I'd say, 40 or 50. And then after having a failed splenectomy, my hematologist said, you have to go back on steroids. So I said to him, okay, but I'm only going to go on low-dose steroids. So I went on 10 milligrams a day for a year, and I would cycle on and off of it. And my platelets actually went up over 100,000 when I was on low-dose steroids. So I'm wondering why we don't start patients at a lower dose, or why don't we use that as more of a maintenance therapy as an option to high-dose steroids?
Yeah. So it's a good question. You would have to, there is some data to suggest that if you've had your spleen out, even if the splenectomy isn't successful, it may reset you a little, and then your sensitivity to other treatments may be different. So it may be the fact that the spleen was gone meant that your steroid response was different. I think that if you start with a very low dose of steroid, the speed of response may be less, and that may be why we start with the higher dose. But there isn't huge amounts of literature about the top dose you should start on. So I think it's a good question. So, for example, for pregnant mums, we do tend to use a lower dose of prednisolone for, you know, obvious reasons. And often that works quite well. So, you know, for the patient who doesn't have platelets of 2 and bleeding, where we prioritize getting it up quickly, it's a good question. Maybe we should be exploring lower doses of steroids.
Thank you very much, Caroline. Any more questions? Where? Oh.
Good afternoon. Note of caution. My wife suffered a bad experience in 2017, double pneumonia, near death. We were in Spain. The protocol there is obviously very different from England, because they, as part of the treatment, used 120 milligrams of prednisolone while she was in hospital, and continued the treatment for 3 to 4 months. And it took, when we got back to England, it took us nearly 2.5 years to bring the dose down.
Yeah.
Happily, she's off now. But it is worthwhile knowing that each country has different protocols, and some can be quite dangerous, in my personal opinion.
Yeah. Yeah, and so there in other countries, so you saw the French average of a milligram per kilogram, the range was 0.5 to 2. So if you're on 2 milligrams per kilograms and you're 60 kilograms, well, that's 120. So you're right, it can be yet higher doses. But I think, that is changing. I think that is an international guideline that says you peak out at 80 milligrams. So I think we are kind of moving away. Also, historically, there weren't that many options. So, if you have a hammer, everything looks like a nail.
Okay, any more questions? I'd just like to add as well to what Quentin was saying about shared decision making. You should all have a copy of the shared decision making document that Quentin was referring to in your packs. So please use that. In addition, there is a new document in there called the ITP discussion guide, which is a sort of questionnaire that you can fill in before you go to your consultation, and it sort of guides you around which questions to ask your consultant. So, okay, thank you very much, Quentin. Thank you.